Okay, good morning everyone, and welcome to the Department of Medicine Grand Round. It's a pleasure to introduce this year's annual Arnold Drapkin Humanism in Medicine Award Lectureship. This lectureship is part of the Advancing Idealism in Medicine program, a resident-founded initiative to promote humanism and idealism in medicine, which, among other things, seeks to bring inspirational role models, such as this morning's speaker, into this Grand Rounds setting so that we can all learn from their example. And the Drapkin Award celebrates humanism in medicine, so it's a fitting part of the AIM Grand Rounds series. Dr. Arnold Drapkin was a superb medical internist who practiced at Mount Sinai for many years. He recognized the importance of science and was known for his humanism and dedication to patient care. In his memory, Dr. Carol Caton, his widow, also a renowned psychiatrist up at Columbia Presbyterian, established this lectureship many years ago. Dr. Drapkin was very fond of the Department of Medicine Grand Round, so this truly is a tribute to him. So now it's a pleasure to introduce this morning's speaker, Dr. Colin West. Dr. West joins us from Mayo Clinic. He received his MD and a PhD in Biostatistics from the University of Iowa before coming to Mayo for his internal medicine residency and chief residency year. He joined faculty at Mayo in 2004 in the Division of General Internal Medicine, and in just 12 years has truly achieved a remarkable body of work. He is currently a professor of medicine, medical education, and biostatistics. He directs the evidence-based medicine curriculum for Mayo Medical School. He's an associate program director for the internal medicine residency training program. He's also the research chair for the Division of General Internal Medicine. And with a PhD in biostatistics, he could have chosen any number of areas to focus his career on. And he's chosen medical education, but more specifically, physician well-being. He's published over 80 manuscripts in journals, in such journals as JAMA and Annals of Internal Medicine. He has lectured nationally and internationally, has been the recipient of numerous awards and grants. And perhaps most notable, he is a role model in driving forward the conversation on why our well-being is crucial to the care that we deliver in our health systems and institutions that we practice. So it's a pleasure to welcome Dr. West. Come on up.
Thank you. Well, thank you, John. It's an honor and a privilege to be here on this occasion, and I'd like to thank the entire Sinai community for the warm welcome. I have no disclosures. I'm a general internist, so that's perhaps redundant. And I'd like to start with just a moment of reflection on a quote from a modern poet, Mark Nepo, who has reflected on his own experiences with a rare form of lymphoma as he's engaged with the medical community in the past. One of the mysteries of illness is that no one can be healed by anyone whose emptiness is greater than their own. So these are the formal objectives, but really what we're going to do is a little bit like The Hobbit. It's a there and back again story. So for the next 20 minutes, I'm going to depress the heck out of you. And then we're going to talk a little bit about the path back. So I'd like you to think about a breaking news story. There's a new illness. It's running rampant in our communities. It affects more than half of certain parts of the population, and that risk is more than double that of the rest of the population. This affects 500,000 people, and as a statistical oddity, that's a similar prevalence to that of lung cancer. It affects our learners and our most highly educated and trained individuals. So, among those who are affected, lots of consequences. Errors, impaired professionalism, job turnover, mental illness, even public safety concerns. And the group that's affected most is also more likely to complete suicides when affected. So what is this? If this were an infectious disease, the CDC would be all over it. We'd be figuring out the triggers, the transmission patterns, and we'd be working really hard to develop effective prevention and treatment options. If this were a chronic cardiovascular condition, what would be happening? Well, the Surgeon General and the AMA would be helping us educate the public to prevent the problem, and we'd be establishing public health programs for support. And I don't know if any of you are Walking Dead or Penny Dreadful fans, but there are other possibilities as well. But of course, you all know that this is burnout. But those are the numbers. So if you've been paying any attention to the media, not just the medical media, but the media in general, physician well-being is something that has been front and center in recent years. We're learning about how common burnout is, how low job satisfaction is among physicians, what the stress levels are like in our profession. We're learning that this affects all stages of physician training and practice, and that no specialty is immune. We all have our own colloquial definition of burnout. But when we talk about burnout in the research world, we're using a very specific definition. I just want to highlight that for a moment. So as constructed by Christina Maslach and colleagues, burnout is a syndrome with three components: depersonalization, emotional exhaustion, and a sense of low personal accomplishment that leads to decreased effectiveness at work. Most of the studies suggest that the low personal accomplishment domain of burnout seems to be most weakly associated with any outcomes or consequences. So many of the burnout definitions will focus only on depersonalization and emotional exhaustion. So what are those? Well, depersonalization is illustrated by this statement: I've become more callous toward people since I took this job. This is the notion of treating other human beings not as humans, but as objects. And if you think about all professional ideals in medicine, this is absolutely contrary to what we hold dear. And yet, someone meets criteria for a high level of depersonalization if, on average, they report this sort of feeling at least once a week. So fairly common. Emotional exhaustion is this feeling of emotionally being at the end of your rope. You have nothing left to give from an emotional standpoint. This is not physical fatigue. This is an emotional situation. I'll go into the data in detail in a few moments, but a brief summary to set the stage for this. And it's important to note this first bullet. Medical students matriculate with better well-being than their age group peers. And then early in medical school, certainly by the end of the second year, this reverses. And that poor well-being persists through medical school and residency into practice. The national burnout rate is at least 54% according to recent national data. As I mentioned already, all specialties are affected, but it may be worst in what are considered frontline areas of medicine: family medicine, general internal medicine, and consistently worst of all, emergency medicine. More than 500,000 physicians in the United States alone are burned out at any given time, according to this prevalence. So I mentioned the information on matriculating medical students. And so this is from a multi-site national study that Chantal Brazeau led. And looking at matriculating medical students and age-similar college graduates, what you see here is that with the stethoscope indicating the matriculating medical students, their burnout rate was lower, and their depression rate was lower as well at the time of matriculation. And this is important data because one of the historical thoughts about burnout that some in medical leadership have suggested is that this is really a problem of recruitment and admission to medical school, that perhaps we're admitting people who are already set up for this because they're entering with these problems. And these data suggest that that's a myth. If we look at quality of life, it's the same story. Across every measured domain of quality of life, the medical students have a higher quality of life. So they're starting with better well-being. And having survived the rigors to meet the standards to get into medical school, it's difficult for me to envision that an entering medical student doesn't have at least as much, if not more, capacity for resilience than their peers. And yet, within the first couple of years of medical school, this is end of the second year data, we see that the burnout rate is higher. It's almost like these bars have flipped. Same thing for depression symptoms. And I won't show you the quality of life data, but again, it's the same. Multi-site study of medical students also found, this is a few years old now, but found burnout rate nearly 50%. 52% of medical students at multiple sites screened positive for depression. Now, this does not mean that 52% of the medical students are depressed. The performance of this tool is such that about 1/4 of those who screen positive would be expected to meet clinical assessments for depression. But it's still a very high number. 48% of our medical students who have endorsed the professional ideals that we espouse had at-risk alcohol use. That compared to roughly 25% for either the Minnesota or the age-matched US population. It's unclear whether alcohol is a coping strategy, but the number is concerning. Looking at residents, the best data we have come from internal medicine residents. We partnered with the in-training examination to survey residents back in 2008. We're collecting data now from the in-training exams to get an update on this. But back in 2008, the burnout rate was 51%. And what really catches my eye here is this depersonalization rate. Nearly 1/3 of our internal medicine residents endorsing that at least once a week, they feel they've become more callous to their patients, treating their patients as objects. That's not the humanism in medicine that we all envision. It's not what they envision, and that's part of the heart of the problem. When we look at practicing physicians, we've partnered with the American Medical Association on national surveys. Back in 2011, the overall burnout rate was about 46%. And again, this concerning depersonalization number. We recently published about 6 months ago the update from the 2014 survey, and every domain of burnout has gotten worse. The overall burnout rate's now over 50%, emotional exhaustion is approaching 50%, and depersonalization is now greater than 1/3. Dissatisfaction with work-life balance, no surprise, has also somewhat worsened. This is a very busy slide, and I don't expect you to look at all the details here. A couple of points. The first is that the top lines in orange are the 2011 burnout rates. The lower lines in blue are the 2014 rates, and every specialty in medicine has a higher burnout rate in 2014 than in 2011. Emergency medicine is at the top there, but every one of these has increased. Some of them are a little bit harder to explain. Urology, for example, took a major jump in 3 years. I've spoken with the Urologic Association leadership, and they're looking into why. They don't have a good sense. I think it's probably a little more complicated than feeling career threatened by PSAs sort of fall from grace. Another point here to make is that even the disciplines that look the best, preventive medicine and occupational medicine, radiation oncology, and so on, their burnout rates are still 40%. So no one gets out of this unscathed. The demographics of burnout are complicated, but in general, burnout seems to be slightly more common among women. It's a few percentage points, so in the big picture, it's probably not that big a difference. Younger doctors may have more burnout, but those data have to be looked at with a bit of skepticism. Because if you think about how we survey, the doctors, the older doctors that are going to respond to surveys about burnout, to be in the survey, they have to be practicing. So a burned out older doctor has already dropped out of those surveys and therefore is not measured. So we may be dealing with a survival bias issue. We don't have the longitudinal data over careers yet to assess truly what happens with age over time. The frontline specialties, as I mentioned, greater number of work hours per week has shown up in every model as a predictor of burnout. Working in private practice rather than in an academic medical center is associated with higher burnout. And when we talk about some of the drivers of dissatisfaction and burnout, there are some theories about why that may be. And an incentive-based as opposed to a set salary structure has been associated with burnout. When these data first came out, one of the questions we were commonly asked was, well, everyone's stressed. All of society is struggling. So this isn't just physicians, and in fact, physicians are protected. We have stable careers, we have good incomes. So stop whining. So we'll talk a little bit about why this matters to people outside of physicians. But as part of our partnership with the AMA, we've surveyed the public. We have population-based sampling data. And I'll point you here to the 2 rows in gold. So for physicians, this uses a slightly different burnout instrument. The full instrument's 22 items long. It's a little difficult to get survey response when you're asking the general public to fill out something like that. So we've tested a shorter 2-item screen that performs very well but does underestimate burnout by 5 to 10% typically. So for physicians using that tool, the burnout rate was 49% in 2014. In the general public, it was 28%. Dissatisfaction with work-life balance, the same 49% for physicians, only 20% in the general public. This is after adjustment for things like the increased work hours that physicians put in. It's not on this slide, but I'll also point out that compared to 2011, we've seen that the physician burnout numbers have increased. In the general public, they haven't changed. So there's something different in terms of that secular trend among physicians. Another question that we had often been asked was, well, okay, but there are stresses of highly trained professionals. And physicians are no different than lawyers. They're no different than biologic science PhDs and so on. And so we looked at that as well. And using as a reference group high school graduates, we looked at burnout rates adjusting for a host of other factors. And so individuals with a bachelor's degree had 20% less, or were 20% less likely to have burnout. Those with a master's degree were 30% less likely to report burnout. And those with a doctorate or a non-medical professional degree were 40% less likely to report burnout. Now, granted, this is lumping lots of different professions together. So I can't give you specific data on corporate lawyers or investment bankers or other groups that may deal with significant stressors. But you'll notice, of course, that I've left one major group off of this list, all of us. So where are we? Well, it turns out that when we looked at degree status in education, physicians were the only group that had a higher risk than the high school graduate. 36% higher risk. So a rate that's more than double our peer professionals. So there is something that seems to be unique to the medical profession about these trends. So, okay, physicians have it tough in terms of some of these issues, but really, who cares? We're well paid, we've got stable careers, we're generally respected, so what's the big deal? Well, and before I get to the consequences, a little bit of some of the causes here. There's something that Gabbard has written about called the physician personality. It's just something to think about here. And this is something he termed the triad of compulsiveness. So we live in a world of doubt, uncertainty, and recognizing uncertainty and dealing with it is actually one of the hallmarks of maturity in the medical education process as our practices mature. When things don't go as well as we would like them to for ourselves and for our patients, we feel guilty, even in the face of that uncertainty. And then despite the uncertainty, we tend to have an exaggerated sense of our own importance and our own responsibility. And if you mutter to yourself, shake your head and say, well, that's not me, I would encourage you to go back and speak with your loved ones and ask them what they think about this triad. Of course, we all recognize that it's adaptive. There are positive features here. We look for medical students and residents that embody some of these principles because it promotes diagnostic rigor, thoroughness, a recognition of the responsibility that the trust patients place in us leads to. But there's a maladaptive component to this as well. Physicians have a hard time relaxing. They often sense that they're not doing enough, even after going an extra mile. And physicians commonly confuse selfishness with healthy self-interest. And this is this notion that actually I just learned about this last weekend from a social ethnographer, pathologic altruism. This idea that we will meet that professional obligation of altruism to our own detriment, not recognizing that when we do that, we actually sacrifice our own ability to continue to take care of the patients that we want to. So I mentioned we get to consequences. So this is one slide with a whole host of data. But what we see here are consequences to patients directly. So whether actual or self-perceived major medical errors in several studies, impaired professionalism and professional behaviors, and reduced patient satisfaction have all been tied to burnout. There are profession issues as well, staff turnover and reduced hours, including a recent study that my colleague Tate Shanafelt published showing that within the Mayo system, where we have actually very low turnover for physicians, even with those low numbers, they were able to demonstrate that burned out physicians, when looked at longitudinally, were markedly more likely to retire early or reduce their effort from a full-time FTE to something lower. That has major implications for access to care, particularly when we think about the frontline specialties that are more affected by burnout. Mental health issues are linked to burnout. I mentioned depression and suicidal ideation. I know that's a very sensitive issue in the New York area, but it's really a sensitive issue nationally. And then public and personal safety, motor vehicle crashes and near misses, beyond the effects of fatigue. So there are significant consequences whether you are an individual physician, a family member of a physician, a patient, or an administrator. So if we put all these numbers together, at any one time we have more than 40,000 medical students in the United States alone who are burned out. More than 60,000 residents and fellows, and more than 490,000 physicians. We haven't talked yet about nurses, advanced practice individuals, and others in healthcare. We also haven't talked about the rest of the world. This is just the United States. With numbers like that, this is really, in my view, a rhetorical question. Is this an individual problem or is this a system problem? More than half of our physicians are affected by this. This isn't about recruiting people that are set up to fail. This is about a system that is not conducive to well-being. Okay, that's the bottom. So now we're going to talk about what do we know about how to get back from that point. So we'll talk about some of the evidence-based approaches, and we'll talk about some not so evidence-based approaches, because I think there's still something to be learned there. As we've looked at this, and you can quibble about the details here, but I think this encapsulates most of what we know about the drivers of distress, drivers of burnout. We've categorized it into what we call the 5 drivers. The first is excessive workload. So I mentioned work hours, but this also involves some newer ideas. Work intensity is another one. We'll come back to that in a moment. Inefficient work environments with inadequate support. So most practicing physicians immediately think of the electronic health record when this comes up, but it's about other aspects of clerical burden, or what Mark Linzer has called the hassle factor of medicine. Almost all of us got into medicine to try and help people. We want to work with patients. And yet there's literature out there over and over and over again that suggests that in the training process, we spend less than a quarter of our time in direct patient care. We spend a ton of time and effort serving the computer, rather than the computer serving us. Problems with work-life integration. So whether that's based on individual choice or from medical systems that set up, for example, grand rounds at 6:30 in the morning. which happens out there. I'm delighted that you're just, not only because I wouldn't want to get up that early, but that your grand rounds is, as inconvenient as it may be when you're rounding and so on, you carve out time during the actual workday for this. That's important. Loss of autonomy, pick your word. Flexibility, control. Some of the highest trained individuals, products of our educational systems, get into practice and feel like they have no control over the minute-to-minute aspects of their lives. Somebody else tells them, you have 15 minutes with this patient. You will see 30 patients in a day, etc. And then finally, and the one that we've zeroed in on the most, loss of values in medicine and loss of meaning from our work. So medical students start, and most medical students have this idealistic sort of naive approach. They want to help people. Medicine is this great, huge world, but they're going to change it, and they're going to help people live better lives, and they're going to be a part of that. An incredibly rewarding dream. And it's actually a dream that we should be helping them with. But instead, what do? We make fun of them. We tell them, oh, you're so naive, you just haven't seen the world yet. It hasn't hit you yet. We say that to our residents sometimes as well. But they're actually the role models that we should be getting back to. We're the ones who've become jaded. We'll talk about meaning and work a bit more as we go. From a sort of broad standpoint, not specifically evidence-based, these are some of the individual strategies that have been proposed in the literature. So identifying our personal values. What matters most to us? Consciously and intentionally integrating our personal and professional lives. And debunking this myth of delayed gratification, which I'll mention on the next slide. Optimizing meaning and work is important. Getting back to that, why did I get into medicine in the first place question, and reminding yourself why you're here. And then taking care of ourselves in all domains of wellness. So that delayed gratification idea, Nita Ratanawongsa at Hopkins reported a number of years ago that 50% of residents reported what they termed a survival attitude during training. They place their lives on hold until residency's over. But we've seen from the data that if you do this as a medical student, do this as a resident, well, the numbers in practice aren't getting better. So what are you putting it on hold for? There's always something else to tax your time and tax your effort. My colleague Tate Shanafelt has looked at practicing oncologists. More than a third of them reported looking forward to retirement as an essential wellness promotion strategy. And if you are within a few years of retirement, that may be reasonable. But what's most compelling to me about this study is that the oncologists that were in their first 5 years of practice had exactly the same rate of looking forward to retirement as an essential wellness promotion strategy. I think that's a little difficult to envision sustaining over what we would hope will be a 30-plus year career. And so many physicians may maintain these strategies throughout their entire career and never actually take care of the present. If we're going to talk about individual strategies for well-being, we have to be able to recognize when we're distressed. And there are some tools out there. My colleague Lottie Derby has pioneered some of this work for medical students and physicians. There's something called the Physician Wellbeing Index that's a simple online instrument. I've not been part of the development of that instrument, so I can't speak to some of the specifics about access and all the rest of it. But it's out there. And part of their work has shown that physicians do not reliably self-assess their distress. We don't have a good insight into what we're dealing with ourselves. They studied 7,000 surgeons and found that the surgeons consistently underestimated their levels of distress relative to the validated instruments out there. But compellingly, when those physicians, those surgeons, were shown how they compared with the national norms, they reported at least the intentionality of making changes. We don't know yet whether they actually put anything into practice. But there was a recognition and at least some intention reported to try and do something about it. So recognition and awareness of our own levels is important, and there are online tools to allow us to do that in an anonymous fashion that can track things over time. And then Christine Moutier, who moved from San Diego to New York a few years ago for the American Foundation for Suicide Prevention, has developed anonymous confidential web-based screening for suicidal ideation. It can link people to resources once they go through some of the screening tools. The AMA has put forward some other modules. They use a slightly different instrument that links more to individual practice pressures, may be more relevant to those in private practice or small group practices than major academic medical centers. Again, from a general standpoint, not specifically evidence-based, what can organizations do? Well, be genuinely values-oriented. So is there a congruence between the values that an institution promotes and the expectations of all of the healthcare professionals at that institution? Provide adequate resources. This is a constant threat in medicine. But it's really important that individuals feel supported by their organization to allow them to do the great work that they want to do. Promote autonomy and engagement. So if physicians feel powerless, why is that? We should all be engaged by our leadership, whether it's physician leadership or administrative leadership, engaged in solutions to all of the issues that affect us on a daily basis. Promote work-life integration. So at Mayo, there have been efforts intermittently, some successes and some failures, to do away with the 6:30 or 7 a.m. meeting, to do away with the 5 p.m. after work meeting. And again, those are hit and miss, but being public about that. There was a Department of Medicine policy at Mayo 10 years ago actually forbidding meetings outside of the 8 to 5 window. It lasted about 6 months. And then finally, promote meaning in work. And this gets back to some of those values. If we look at the evidence specifically, I'll speak to a systematic review on interventions for physician burnout that we were commissioned to do by the Gold Foundation last year. It's currently under peer review. The abstract's been published. And we found 52 total studies on interventions, which in and of itself is impressive because about 5 years ago there were only maybe 15 or 20. So there's been a major explosion of interest in people moving from the epidemiology to testing interventions. The results have been similar so far for the randomized and non-randomized studies, which is helpful because it allows us to pool the evidence a bit more than we might otherwise have thought we could. And I won't speak to some of the details here in great detail. About half of the studies have been of residents. There have been 10 studies so far on duty hour requirements. This does not include the iCompare or first trial results for a couple of reasons. iCompare hasn't come out yet. That's a study of duty hour, a randomized study of duty hour requirements. And then the first trial, which has been published, was a randomized study of duty hour requirements among surgeons. First trial is among internal medicine. Now, the problem with the first trial is it did not use a validated measure of well-being. And so it would not be eligible for this systematic review. And beyond that, I think it's difficult to know what to do with some of the well-being information from that study. However, if we look in total, and we'll focus mostly on the absolute rate of high emotional exhaustion, depersonalization, and burnout, we see that across interventions, they reduce the absolute rate of emotional exhaustion by 14%. A little bit less of an impact on depersonalization, but it is just statistically significant with a reduction of 4%. And if we look at summary definitions of burnout, these individual interventions across studies on average reduce burnout by 10%. The individual focused and structural interventions give similar results, but I think it's important to recognize we need both. This is a shared responsibility. It's been very common in medicine to make this an individual learner or physician responsibility. We're going to send you to stress management training, usually from 9 to 12 on a Saturday. And that gets interpreted by learners or practicing physicians, really, if they think about it, as a deeply cynical leadership approach to say, we're not going to take responsibility for the environment that you're working in. We're going to give you the skills to cope with it better, which is not the right message. Yes, we all need skills to help cope and be resilient with the stresses of our workplace, but we need to feel actively supported by our organization as well. Our organizations and their leadership should be promoting healthy workplaces that allow us to work at our optimal level. What are these individual-focused interventions that have been studied in these interventions? Well, meditation techniques, mindfulness-based stress reduction, communication skills training, and a variety of different kinds of small group curricula. And we'll come back to these in a moment, but they're really important for the meaning aspect of medicine. They promote community. They reduce isolation. They promote connectedness. From a structural standpoint, there have been quite a few studies, as I mentioned, on duty hours. They seem to be beneficial for trainees. There's been some debate in the past about whether duty hours improved well-being. We know they've improved fatigue. At least from a burnout standpoint, duty hours have improved burnout if you look across all of the studies. Their effect on attendings, I'll be generous and I'll say unclear, but I think most people think it's actually probably had a somewhat negative effect on the well-being of attendings. And locally developed practice interventions have been tested. Mark Linzer and others have pioneered work there. I mentioned the small group approaches. I'll tell you just in one slide each a little bit about a couple of trials that we've run in the Department of Medicine at Mayo. The first one, published in JAMA Internal Medicine in 2014, involved facilitated small groups. We had professional facilitators who had communication skills training, groups of approximately 8 colleagues who were put together, and over 9 months every other week, they met to review topics relevant to the physician experience. And the details of the curriculum are available in the publication, but what we found was that this reduced burnout, improved quality of life, generally improved well-being in the randomized intervention arm more than the control arm changed. And 1 year after the group stopped meeting, those benefits were sustained. I think it's worth noting at this point, however, that the specific aspects of this intervention that are effective and the exact format that is most effective remains a knowledge gap. So I know Dr. Rip here at Sinai worked on trying to roll a similar sort of intervention out among the internal medicine residents here. And with slight adaptations to the approach, it really wasn't as effective. And so we still are learning what works and what doesn't. Well, our organization said, you know, we're willing to support this for all of the physicians. But the first intervention, we provided protected time. It wasn't much. It was 0.9% FTE to allow that 1 hour every other week. But they said, you know, if you could come up with something that was even more efficient, maybe it didn't take even that 0.9%, because over the 650 physicians we have in our Department of Medicine, that adds up in a hurry. And it does affect patient access and so on. So is there something else you can do? We'll support it if we have to, but is there something else you can do? So our subsequent intervention was to say, okay, let's not provide time, but let's get the groups together and let's let them meet over meals that we pay for. So we'll provide dollars. Institutionally supported physician meetings where we pay for them in groups to meet every other week for an hour. For the first 15 minutes, their commitment is that they are going to review one of a menu of topics related to the physician experience. That may be discussion of errors, that may be discussion of gender differences in medicine, that may be a discussion of integrating work and home spheres. But they have a set curriculum that goes on for this. And so we ran that for 6 months and found almost identical results. Improvements in depersonalization, quality of life, reductions in depression, reductions in social isolation at work, and reduced likelihood of leaving in the next 2 years, at least by self-report. And so on the basis of these results, our institution last October actually rolled this out to all physicians and research scientist staff at the institution. So it's available at this point at Mayo for everyone across the entire, not just Rochester, but also the sites in Florida and Arizona. and the community practices in the upper Midwest. There are 3,700 eligible physicians and scientists. In the first 6 months, 1,000 have enrolled. And we just got 2 weeks ago our first survey results back as an interim check on satisfaction with the intervention, or the groups, I should say. And 97% of the respondents indicated that Mayo needs to continue to fund this program and that they want to keep meeting either in their group or in a different group. So nearly a third of the faculty taking advantage of this. It's a shared responsibility effort. The individuals are making the time. The institution is providing the resources and very public support with videos and announcements from leadership across the institution, encouraging people to at least check it out. So as we think about what the solution matrix should look like, we've got our 5 drivers along the rows, and this idea that some of these need to be individual focused and some of these are an organizational responsibility. What solution is going to be the most effective in a local area really is something that needs to be individualized. The drivers of burnout are different from work area to work area, from institution to institution. But this matrix may be helpful in at least plotting out where those interventions should be. And if you think about what some of the options may be, whether from an evidence-based standpoint or just thinking more generally, some options come up. So from an individual standpoint, what can you do if your workload's too much? Some of you may be more innovative than I am, but I think the options are fairly limited. To cut down your workload, you have to see fewer patients, you have to go part-time. Maybe there are other options out there. From an organizational standpoint, though, there may be a little bit more on the menu. So why do you have to see X number of patients in X number of time? And how does that map to the values and meaning piece of medicine? How do you engage physicians in trying to blend productivity targets in a way that makes the workload manageable? Doesn't necessarily mean reducing the workload, by the way. It may mean simply redistributing it in a way that is more tolerable. From a meaning and value standpoint, individually, yeah, appreciative inquiry, positive psychology, mindfulness, small group approaches for community. Bringing yourself to that, to engage with your colleagues, recognizing that you are part of a great profession, engaging with your colleagues. All of that mindset's really important. But from an organizational standpoint, there has to be an authentic endorsement of that meaning piece. What are the core values of your institution or your department or your division? And do you live those? And as leadership, do you authentically promote those? So some summary recommendations. This is a major issue that we have a professional obligation to act upon. We've seen it's a threat to our profession. I think it's a public health issue. And in fact, about 6 weeks ago, the Surgeon General said as much. First time ever. And I would argue that although we sometimes think that taking care of ourselves is unprofessional because it's not putting the patient first to our exclusion, I think it's actually unprofessional to allow this to continue. And this likely means that we need to evolve our definition of professionalism. If you think about the Charter on Professionalism that's accepted internationally, there is a section on altruism, but there is nothing in there about physician well-being or self-care. And I think we have ample evidence at this point that we have to take care of ourselves to be able to take care of our patients. Again, this is a shared responsibility. It's not just us as individuals, although that's important. We can't wallow in negativity. But our organizations and our leaders need to partner with us. And that's starting to change. The ACGME hosted a symposium last November. I just met with the AAMC Leadership Forum last week in DC. And Daryl Kirch stood up and said, we have enough data, it's time for action. Major shift in attitude. So we're starting to see this tip. We need to be able to assess distress. And there's really no reason not to, because we have actionable confidential tools to allow us to do this. This should be a metric of institutional performance. This is not a new proposal, by the way. Wallace, Lemaire, and Ghali proposed this in Lancet in 2005. Most institutions still don't do it. I'm happy to say 4 or 5 years ago, Mayo added it to its all-staff survey. So well-being, burnout, questions like that are part of the all-staff survey for all 40,000 Mayo Clinic employees. It's anonymous. We don't know who says what, but we can certainly get work unit level data to get a sense of where some of the hot spots are and where are the areas that are handling this well that we can learn from. We need better studies. I won't read the bullet points on this slide, but some of the novel factors remain unexplored. What's the role of work intensity? And we still have epidemiologic work to do. We don't know enough about burnout in underrepresented populations in medicine, for example. So we need more data on those kinds of groups. But the research should develop interventions that targets those 5 drivers, thinks about that matrix that I presented, at least as an organizing structure for the work. One size does not fit all here. The toolkit is going to contain many different tools, which is daunting because it means there's no one solution. Even with our small groups that we've rolled out, while it's great that 1,000 physicians have signed up and are building communities, 2,700 physicians and scientists have not. They're looking for different solutions. So we need to have a menu that gives them something as well. On the plus side, the systematic review suggests that many approaches can offer benefit. And maybe if we're able to combine those approaches, combine both individual and organizational strategies, we'll see a synergistic effect in reducing burnout. So again, think about the 5 key drivers, think about individual and organizational responsibility, and think about how that maps to potential solutions for each of your local environments, whether it's a clinical area, a training program, a medical school class, whatever it might be. What can you do to deal with workload? How can you promote an efficient environment that gives people the right support and lets them do what they love to do? See patients, do meaningful research, make an impact. Help people deal with that interference between the work and home spheres. Engage people in developing solutions. And authentically promote meaning in medicine. With that, I'll close. I'd be happy to take comments and questions. My email's there. I'm new to Twitter, but if anyone wants to engage there, I'd be willing to do that as well. Thank you very much. Again, it's an honor to speak with you.
Please time for some questions. Thanks very much. I don't think you mentioned the powerful role of finances, government finances, hospital finances, group finances on the practicing physician. It seems to me there's been a huge acceleration. For example, in humor, God forbid somebody be readmitted within 3 days of hospital discharge. So this is a huge pressure on all of us in medicine. Perhaps you could comment on that.
Yeah, and I think, so the question is about the financial pressures on medicine and the ever-accelerating sort of hassle factor, which I'll go back to, of the practice, coding things properly, et cetera, and what's the impact there. I think that's one of the reasons why the fee-for-service, non-salaried private practice physician struggles more than the academic person. Because even though in academics you feel that pressure, it's way worse in a private practice. But it is clearly a problem, and it goes into that work inefficiency piece because it's not really part of medicine directly. And I've had colleagues who have argued, no, the coding and the billing is part of your job as a physician. Okay, I get that to an extent, but really, let's not take it too far. At dinner last night, I told the story of one of my colleagues who sent me an email yesterday, actually, complaining that he's attending on hospital service right now, and a June intern, she's outstanding, was managing a patient, And one of the admitting diagnoses was acute on chronic renal failure. And she gets a note from the billing and coding people saying, well, it's better from a coding standpoint if you write, acute on chronic renal failure is medically okay, but it's better if you can write acute on stage 3 chronic kidney disease, which is what this patient has according to our review of their notes. Well, rather than them going in and simply updating the record to reflect that and then asking her to click approve, no, they won't do that. They will tell her what she has to do. She was off for the weekend. She was fortunate, had a 2-day off in a stretch thing. Wasn't there to get the message. Comes back Monday with this. And because it hasn't been addressed over the weekend, is now dealing with a threatening email saying, if you choose for some reason not to comply with this recommendation, you may do so, but you will be required to appear before the chair of the coding committee to explain your reasoning. I sent a note back last night to my colleague after he shared this story saying, well, this is exactly what people are talking about with the hassle factor in medicine driving dissatisfaction. So I think the financial pressures are part of the problem. I also think, though, that from a medical leadership standpoint, as much as we like to complain that we haven't been at the table for those decisions, we have been. And some of our leadership and some of our representation has allowed these things to progress. And that is also starting to change to some extent. Some of you will be aware that Chris Sinsky, who's a community physician from Dubuque, Iowa, is now part of the leadership team at the American Medical Association. Say what you will about things the AMA has done well or hasn't done well. They are finally, with her really pushing this, they have as one of next year's strategic priorities physician satisfaction, particularly in the sphere of clerical burden and financial concerns. So I don't know where that's going to go. I agree with you that it is a driver of one of those main contributors, or a contributor to one of those main drivers of distress. I think organizationally we could do better to support our physicians in dealing with those issues.
So on the note of what leadership sort of allows or condones, I think something that contributes to burnout is some of the lack of respect between colleagues, not only within physicians, but within all of the employees in the hospital. And not to say that Sinai is the only offender of this. I think a lot of us came here because people actually treat each other mostly with respect, but we still always have been on the end of someone who you feel like you didn't deserve the way they talked to you. And I don't think that there's a lot of effort from leadership to say that's not okay. And again, I don't think that's unique to Sinai. I think that's true in all of medicine. And I'm wondering sort of your thoughts on that, whether you think we need more of a sort of education for leaders about how to say it's not okay for people to treat each other with disrespect.
Yeah, no, I think a culture of mutual respect is a crucial piece of this. We need to respect each other. Institutions, I think it is an example where institutions, almost all institutions have policies in this regard, anti-bullying and so on. But you have to role model it, and it has to be authentic. And when people violate those policies, they really should feel like they're the outliers, rather than looking to that ideal role model. Oh, wow, he or she is great because they're always so respectful of everyone. Why should that be unique? That should be the norm, and anyone who can't meet that standard should be the one who's on the outside looking in. So I agree with you completely, and it's a big part of why many people think medical students struggle with burnout and distress, because they feel like, for a whole host of reasons, they don't have representation. They're struggling with trying to find their place in the professional world, and in the midst of all that uncertainty, then feel sometimes bullied or disrespected. And so we really have to give attention to that as institutions.
Thank you. I wonder if you could comment on why you feel on that slide where every burnout has so much increased in 2011. When I was, some of us were interns in the 70s, there were a lot of hassle factors. They were just different. We had to call every lab and write down every lab result. We worked for, 36 hours without sleep. You were never allowed to call your resident. There was no mutual code of respect. But I think the difference now is that we have lost control over our patients. Where I, as a geriatrician, spend a half hour with a patient, the ratio of time spent arguing with an insurance company, justifying a medication, worrying about RVUs, losing control over how I think I should take care of my patient, how long the patient should be in the hospital, any of those things, I think is what's causing the burnout, where you don't feel that even as a senior physician, you can take care of your patient correctly without a million governmental regulations and stupid things like PQRS and all this other nonsense that isn't really measuring anything.
Yeah, so I'll say two things to that. The first is we don't really know what was going on with burnout in the 70s and 80s, even into the 90s. We just don't have historical data on burnout. And I'm not sure we'd be able to find it because fatigue was so overwhelming prior to duty hour regulation, for residents in particular, that I'm not sure they'd stay awake to fill out the surveys anyway. But I agree with you completely that this issue of, okay, you were up for, and my personal record was 40 hours at a stretch, and people who trained in the 70s and 80s would probably laugh at that. But you were with your patients during that time. That direct contact, that reminder of, okay, I'm exhausted, I'm dealing with a lot of nonsense, but I'm with my patient at least. I have that ownership, I have that autonomy. Why I'm in medicine is staring me, the whites of the eyes, right there. And if you're drawing your own blood cultures, I remember as a medical student watching a preliminary ophthalmology intern try and draw blood cultures on a drug-addicted patient where the only possible access was between his toes. And she'd never done this before, and she was exhausted. But she had hands on a patient's feet. And I remember thinking, how is she doing this? She's clearly a little frustrated and tired, but there's something meaningful about what she's doing with that patient. And that's a struggle now because we have all of these interfering factors, and it goes back to that, the data on less than 25% of our learners' time is spent in direct patient care. I'm not sure it's all that much greater in practice. I think it's a little more than that, but we don't spend our time doing what we all got into medicine to do. And whatever that is, for some people it's not 100% clinical time. For some people it's translational research or whatever it may be. But we don't spend enough time doing what's most meaningful to us. And that's a huge driver of dissatisfaction and burnout in particular.
One last question from back there.
Thank you, Dr. West, for this talk. It's actually very beneficial to someone like me in this stage of my career. And I was wondering if you have any advice for someone who's starting out their career because of the nature of the training and the residency programs, where, as you've shown with your data, in the beginning of the training, you have a certain mindset that shifts towards the end. So do you have any advice for how to navigate the culture when there is some lack of autonomy? Is it that we kind of have to kind of grit and bear what culture we are and wait until we're in that position to make changes? Or are there any advice you can give to someone to make changes even from the beginning? So what would you suggest?
Yeah. So I would say, from a prevention standpoint, preferentially choose to work in disciplines or institutions that are a little more enlightened than others. Once you're in an institution, if there are issues, engage with leadership. And what we found is it only takes one or two enlightened leaders to pull changes forward. And then finally, build your own network and community. Do not become isolated, because whether you're a medical student or a resident or a practicing physician, we support each other. And once you become isolated, once you start feeling like you're an outsider within this profession, it's really, really difficult to cope with all of those other issues. And that's when people sort of go into this downward spiral. So build that community, and hopefully your leadership will help you build that community and endorse that as a really important part of it. People talk about when they choose residencies, well, I got there and it felt like a family. That's the kind of training program you want to be in. If it's, well, yeah, it's great training and everyone gets better because they're always sniping at each other and they learn through that competition. That's going to be a really challenging environment for well-being. Because if you're at the top of that totem pole, maybe you can get through relatively unscathed, at least from a professional standpoint, but you're not always going to be. I mean, this is the thing you go through training. You know, many medical students, it's, you know, you were the smartest person at your college, then you get to medical school, and by definition, half of you are below average. And in residency, you know, you did great in medical school, you get into residency, well, half of you are below average. How do you deal with that? Well, you deal with it by what's your goal in medical school? What's your goal in residency? What's your goal in medicine? What's meaningful? How do you learn to take care of patients? And how do you help each other build a community that nurtures that?
Great points to end on. Let's thank Dr. West.